those.
Yeah, I don't know, John Broach is the director out there.
Looks like we're recording now.
Yeah.
And at least 2 or 3.
Okay, let me find the
Yeah, I
chat.
doubt it. He's pretty busy.
Yeah.
Call messages, no.
Does clinical time, he oversees Chopper and.
Yeah.
No, good to have it anytime.
Yeah.
I try to do, we do a didactic session the first hour, and the second hour you just go over lunch.
People, that's almost 4.
And we got the numbers, Marty got the numbers.
I have the numbers, yeah. That's all good.
I see we have a new young one here tonight.
Yeah.
Yeah,
Yeah.
Yeah, well, you know, she's here to supervise me,
yeah, I
keep me
figured
out of trouble,
she's keeping an eye on you from behind, you know.
something like that. Okay,
Almost.
how about this?
So I just down, so I'm in camera view.
Yeah, I need it the other way around. I need this to be the female end and this to be the male end. Same problem here.
What are you trying to hook up?
Well, I bought a wireless microphone because one of the complaints has been like some of the sound quality stuff.
Oh,
But
yeah.
apparently the wireless microphone that I bought that was supposed to be able to work with.
I mean,
Oh, that's the one you were telling me about, you got it.
Yeah, but it's not really working. So that,
You
we'll just
still
have
have
to use the
the
microphone on the camera.
You
This is
still
a
have the
new camera,
receipt?
so,
To
What's
send
that?
it back?
yeah, it's an Amazon product, so.
Yeah.
But, okay, everybody online, if you would be so kind as to, in the chat, put your name as it appears on your card and your EMS number so that I can put you on the virtual roster. And at the end of this first hour, we'll log off and then come back on for the second hour because they're 2 separate meeting notes. Oh, hang on. Getting some text messages here. So Marty says he's on, but he can't see the chat.
Mhm.
Well, some people.
Yeah. It's on our board anyway.
Oh, there he is. Okay, cool. So we got Marty now.
Okay.
All right, awesome. I need glasses, new glasses. This is why that the transcript is recorded.
Yeah, that's right.
All right.
Okay.
So I don't know that we're getting anybody else, so might
Yeah,
as well get
I
started.
thought maybe we might be thin tonight because we're so close to Thanksgiving.
Yeah, there was that too.
That's okay.
what's over the turkey?
Yeah, I brought a turkey and you're looking at him. So hi, everybody out there. I appreciate you coming in on the Zoom call or Google Meet, I guess, technically. So thank you for everybody. Thank you for being here. I appreciate the time. And as you know, I really love doing this. This is one of my passions is to, the better trained you are, the better it is for all of us, especially our patients, So tonight I thought we talk about something that we see a lot of. As soon as you're ready, tell me to put the slides up. But we all see and all have had cases of shock, and shock comes in different colors. As far as etiologies are concerned, as far as what is causing the shock, but ultimately at the beginning it looks the same. Your patients look absolutely terrible, and is sometimes those are the patient calls that make you have diarrhea and get your heart rate up, because those patients are really sick and they often deteriorate very quickly right in front of your eyes, and it's often in the back of the ambulance that they decide that they're going to crump rather than where you have the resources. You guys know better than I how limited your resources really are out in the field. It's creepy. So what I thought I would do is just to make it a little bit more comfortable for you, give you an overview of what shock really is, how it's defined medically, what we normally call shock and where it comes from, the etiologies. Actually understanding where shock comes from and what causes it will help you treat it. initially. Obviously, I don't expect you guys to give antibiotics for septic shock, but if you recognize that a patient has septic shock or could because they've got a fever and they've had an illness, it helps us prepare on the hospital end, and we can get antibiotics into them within the first hour, which is kind of standard of care, actually. Because, just as a side note, it has been found in research that the earlier we get antibiotics into these people, the better the outcome. It decreases their mortality. So you can make and do make a difference. Yeah, that's cool. So I don't expect you to give ceftriaxone and vancomycin and rig. Be nice, but
So go give them what it is.
it's a little beyond your pay grade. Yeah, I'll just add it just for kicks and giggles. Hey, how you doing? Just getting started. Of course, the big thing for all the providers in the pre-hospital setting is actually recognizing the disease. So when you get to the scene and you see a blood pressure of 80 over palp and tachycardia in the 120s and a sweaty patient, you know, that's probably one of the things that you should think of in the first part of your differential is could this patient be in shock? And of course, the answer is yes for purposes of the thing. But when you guys evaluate and see a patient, it's very important, as you know, to go through in your mind, what else could this be? What is the worst thing that this could be? Is this a heart attack? Is this a PE? Is this septic shock? Is this anaphylaxis? You know, and then work backwards, because the worst case scenario is where you can make a difference. So that's why we're doing all this, and then we'll talk about the initial treatment. Okay, Tom, we're ready to go on.
Marty says antibiotics will be in the next couple of protocol updates, so they're coming.
Oh, sweet. Thanks, Marty. And you'll be the guinea pig. We'll expect you to try it out first. Okay, so the definition of shock is basically a supply and demand issue. And for those of you that really like economics, this is right down your alley. I'll read the definition off the slide so we're all on the same definition, because it words a little bit different in different literature. But basically, it's a state of cellular and tissue hypoxia, lack of oxygen due to either reduced delivery or increased consumption. That's the demand. Inadequate utilization of what oxygen is there. It's just not being used correctly, or a combination of all the above. So basically, in supply and demand economics, on the supply side, and we'll use Amazon as an example since we were talking about Tom. Amazon is not supplying the widgets that the customers want. So all of a sudden, at the manufacturing level, the widgets that are demanded by all the people at Christmas time just aren't being manufactured. So in the human body, oxygen is not being supplied very well. This is the patient that is truly hypoxic in the sense that they need it. So this would be the COPD, for example, or a patient who is being smothered or asphyxiated from something, facial injuries from a car accident. You can think of a million scenarios. So the supply just isn't there. Boom. Another example of that would be the mountain climber that's going up Mount Everest, that all of a sudden the supply of oxygen is only 40 parts per million in the air, in the atmosphere, instead of being what it is, nearly 100 parts per million at sea level. Supply, is not there, and the patient suffocates. So that bad news bears. So Amazon can't supply the widgets, that's supply. On the other side of the coin, they've got all the supply, but the distribution is poor. So Amazon sends their supplies to these different warehouses around us. We just got a new warehouse in Charlton, by the way. I live in Spencer, and Charlton's the next town over, and they just built this mammoth warehouse for Amazon. So all of a sudden, the warehouse can't distribute it. All of a sudden, the truck drivers say, sorry, Charlie, we're not showing up for work. So all the widgets are in the building, but they're not being distributed to the customers, and the customers are screaming. So that's distributive shock. That's where the oxygen is being delivered to the patient, but the patient is not distributing the oxygen correctly. Breakdown of blood vessels, capillary leak, muscle deterioration, heart that isn't pumping, whatever that may be. So the distribution of the oxygen is poor. Another classic example of that would be where everything just collapses and the patients are in, widespread bleeding, for example, or, hemorrhaging. The distribution is really poor. So that's distribution. And then the other end of that coin, we've got Amazon making the widgets. We've got the warehouse distributing the widgets. But when they go to the door, the customer isn't home. So the widgets aren't being used properly. That's poor utilization of the oxygen at the tissue site. So that might be ischemia. That might be where the blood vessels just can't push the oxygen into the tissues. That could be due to a blood clot, obstructive shock like in PE, an MI, that sort of thing. So we have supply and demand issues, and that's basically what shock is. Another definition, this is off of the national definition off of the literature. It says that it's life-threatening manifestation of circulatory failure. That's a really good way to think about it too. So no matter what is behind the shock, whether it is hemorrhaging or PE, a heart attack, a stroke, it's a lack of circulatory failure. So, or it is a circulatory failure problem. Okay, this leads to cellular and tissue hypoxia. And as you guys know, the longer the tissue is hypoxic, the worse it is. How long can brain tissue be hypoxic before it starts to go? What's that?
Was it 4 to 5?
Yeah, 4 to 5 minutes. Yeah, boom, down you go. Same way with cardiac tissue. Renal tissue, a little longer than that, but you get the picture. This leads to death and destruction, dysrhythmias, and so forth. And the effect is reversible in early stages. And that's where you and I come in, because if we can interface with the patient early in the game, we can make a difference. Obviously, the later they go, the worse the outcomes. We'll talk about the stages of shock in just a minute. And ultimately, what happens is shock can lead to end-stage organ failure. Multiple organs can be involved, namely brain, kidney, heart, and liver. Those are the big four. You can also lose muscle and skin along with that. But those are the big organs that we look at. And when we're doing lab work, those are the organs we're looking at primarily. We're doing liver enzymes. We're doing CPK, looking at the muscle. Of course, we're looking at a troponin for the heart, and so forth. Okay, next slide. Thanks, Tom. Oh, I forgot to tell you the origin. Where did this word shock come from? It actually is a French word, choc, which came from Dr. Ladan way back in the 1700s. But shock was actually known well before that. Even the Egyptians in some of their old ancient literature described shock. They don't use the word shock, but they describe patients as collapsing, and it's in the Greek literature, Romans. It's pretty cool. So it does go back as far as man goes, but it was a Ladan. He was a physician surgeon back in 1743, and the word stuck because it's a shock to the system that happens rather suddenly, where the patients suddenly become very ill. Okay, next slide. So we're going to go through the 4 types of shock, and this is really great information to know, because if you have it sorted out in your mind, then it can sort out your treatment, because your treatment algorithm is a little bit different, depends on where you go. Okay, the first is distributive shock, and distributive means that the shock to the system is distributed throughout the circulatory system. So basically, distributive shock, guys, is peripheral vasodilatation. It's a collapse of the arteries and the capillaries and the veins to do what they do. There's some examples on the slide for you. One of the biggest that we see and the most common is due to sepsis. Why? Because the toxins in the bacteria actually destroy the basement membrane of the blood vessels and allow the blood vessels to leak. And when that happens, the pressure in the vessels drops. You get leak of tissue fluid and blood cells and so forth, and you get this whole cascade of inflammation and inflammatory response, and as a result, the patients are really sick. Sepsis is great, and it's probably the #1 reason for distributive shock, and that's why these patients do so poorly. And that's a contributor to low blood pressure, hypertension. Okay. Another one in this is anaphylaxis. Same thing. The patient is exposed to a toxin or something that they're highly allergic to. It sets off a huge inflammatory response. Generally, it's IgE mediated. For those of you that remember pathophys from school, it's IgE mediated. What happens is you get this huge release of basophils and eosinophils that are releasing prostaglandins and all kinds of like bradykinin and so forth. What these inflammatory things do is cause a marked increase in the inflammation inside the cell walls. Membranes collapse, you get the capillary leak, and this huge inflammatory response which causes the patients to flush, become high-V, and then they lose their blood pressure. They start having trouble breathing, airway goes shut, and next thing you know, you've got a really sick patient on your hands. So this is a distributive shock. It kind of overlaps a little bit with some other forms of shock as well. But basically, take it for what it's worth, anaphylaxis is something that's treated a little bit different. In addition to fluids, we always give what drug? Epinephrine, right? So epi's a big one here. Neurogenic refers to an insult to the central nervous system. This would be either spinal shock. This could be trauma. This could be an abscess. This could be an infarct to the cord. This could be a disease process like multiple myeloma, tumor on the cord. This could be a stroke. Strokes are very well known for causing shock in a lot of patients. Depends on where the stroke is located in the brain and what blood vessel system is involved. Most of the time, our stroke patients are either hemorrhagic or thrombotic, and thrombus most of the time is in the anterior circulation because that's 80% of the circulation to the brain is anterior. About 20% is posterior back here with the vertebral arteries, and that's usually the dizzy, disequilibrium type of patient or the vertiginous patient that gets a posterior stroke. Most of what we see in common everyday word is the anterior stroke. But nevertheless, they can go into shock too. Have anybody in the room, have you had a stroke patient that got shocky, picked them up and they're hypotensive and tachycardic? Yeah, very much so. And keep in mind too, and all of you have probably seen this too, neurogenic shock often is bradycardic, not tachycardic, because the blow to the sympathetic nervous system shuts off that fight and flight response, and all of a sudden now your patient's bradycardic and hypotensive. So that is shock. It's not a vasodilatory shock, is it? It's more neurogenic because of the insult to the sympathetic nervous system. So what takes over is the parasympathetic nervous system, and they get sweaty, diaphoretic, bradycardic, hypotensive. So pretty sick patient. Number two, cardiogenic, and I'm sure all of us in the room have seen cardiogenic, and all of us out in Google land have seen cardiogenic shock before. The big MI that suddenly it's an inferior wall. Inferior walls are notorious for dropping the blood pressure because that preload is reduced, right? RV pressure is dropping, the preload drops, and as a result, the tank just suddenly loses its pressure. The patients end up becoming very hypotensive, and RV infarcts can often get bradycardic as well. So cardiogenic shock is the decrease in pump pressure. Pump failure decreases cardiac output, and I'll talk a little bit more about where cardiac output fits in all those nice formulas that you remember from pathophys in a little bit. I know you're excited. But cardiomyopathies are famous for this too. These are patients with pre-existing hypertension. They have hypertensive cardiomyopathy, or the patient that has undergone a tremendous loss of the spouse or their child, and they all of a sudden develop chest pain and go into shock, and that's Takotsubo's cardiomyopathy. Yeah, it's very rare, but it happens.
I had a patient that had that.
Interesting, isn't it? Yeah.
Every other week, presented as a STEMI. They'd go on, clean as
Did they have some kind of like a grieving thing hit
It
them?
was just a like it went on for like a period of 6 months. It was just coming on.
Wow, yeah.
Yeah. presented
It can
as a
be
STEMI.
genetic,
Yeah,
yeah.
it's presented as a STEMI, we go to cath lab, go in, clean as a whistle.
Yeah, and their ventricle looks like the head of an octopus.
Yep.
Yeah,
Yeah, that's why I remembered it, the octopus crab.
really dilated, yeah. Wow, it's interesting.
Mhm.
It often reverses itself over
Yeah.
time, yeah. But interesting, yeah. Yeah, their cardiac output and their EF is in the toilet. Yeah, no pump, basically it's just a big dilated, right, RV and LV. Yeah. So cardiomyopathies can do this, and they come from pulmonary hypertension, Takotsubo's, if I'm pronouncing that right. Yeah, but there's all kinds of reasons for that. Bumps, measles, viruses can cause cardiomyopathy. Can COVID cause cardiomyopathy? Absolutely. I'm sure you all have heard or seen cases where COVID infections post-COVID have developed cardiomyopathy. Shock in the ICU, for instance, someone has come in with sepsis, they're being treated, and all of a sudden they go into a cardiomyopathy shock. That can happen. It can happen after MIs as well. So arrhythmic, big time, and an obvious reason for that, if someone's in sustained VTAC or VFib, AFib RVR, if they're in third-degree heart block, you can imagine what that does to the pump. The pump needs electricity to work, and if it doesn't operate right, then they go into pump failure. It's pretty obvious. Anyone that's had a pump failure in their sump pump, they know what that's like. Yeah, or the power goes out and it's a flood, heavy rains, and sump pump doesn't work. Had that happen in Ohio in our house. Destroyed the first floor. The basement got all flooded. It was just a mess. Mechanical failure, as you know, there are patients who have valvular disease, and if the valve goes bad, the patients can go into shock. Mitral valve stenosis, aortic stenosis. If the patient has a leaflet that suddenly ruptures, those little muscles that hold the leaflet are called papillae, and if they rupture for whatever reason, the patients can go into heart failure and shock pretty quick. I mean, it's a matter of minutes. There's no mercy there. Aneurysms can do this too. If the aneurysm is off the aortic root, if the aneurysm starts to dissect or leak, they can go into cardiogenic shock pretty quick too. So just a few etiologies. And why is this important to me, Dan, in the back of the ambulance? Because if you have a shocky patient on arrival and you do the 12-lead or 4-lead or a rhythm strip, and you see the dysrhythmia there, you see the tombstone elevation of an infarct, it kind of gives you a lot more information as to why your patient is sick. And that means you can treat it, right? So if you have a patient in heart block, you know what to do. If you have VTAC, you know what to do. If you have an MI, you're trained to do that. So you can interface right away with your shock patient rather than second guess why your patient's hypotensive and tachycardic. So those are the first two, and cardiogenic is fairly common as well. Next on the list, Tommy can flip the slide a bit for me, is hypovolemic, the most common reason of shock that we see. And everybody's seen this. The patient is dehydrated, nausea and vomiting, diarrhea, gastroenteritis. The patient is hemorrhaging, car accident victim that's got a liver lac or a splenic lac, the crush injury. These patients are really hypovolemic. They're losing their blood volume. So volume inside the blood vessels is compromised. And when the volume drops, what happens to the blood pressure? The blood pressure goes down the toilet, and the next thing you know, your patient's in shock. Shock and hypovolemia is categorized in two ways, just for teaching purposes. It's either hemorrhagic or non-hemorrhagic. And at the scene, it's often difficult to tell the difference because a patient in an accident could be hemorrhaging, but then again, we don't know if they wrecked their car because in the last 2 days, they've become hypovolemic because they've had the GI bug. So they're driving to work not feeling well. I'm going to try to go to work today, but I've had diarrhea for the last 2 days. And they have a syncopal episode at the wheel, and they hit the guardrail. So you respond to the scene as a car accident, and you're starting to do the history, and the patient's kind of obtunded, and they're in and out. So you don't know. They can't give you a good history. And so you have to assume the worst. Are they hemorrhaging? Or are they hypovolemic? They have a syncopal episode. Could the syncope be due to cardiac dysrhythmia? See, I'm giving you all kinds of Where do I go? Where do I go? The first thing you do, I'm jumping a little ahead of the lecture here, is you treat what you see. If the patient has a pressure of 85 and a heart rate of 112, first treatment of choice, besides the oxygen that you're giving them, is fluids. Yeah, you guys know what to do, right? So you're actually treating shock, and then a little while later, then you can start sorting it out. Or call the doc later and say, hey, what'd you find? You know, like, oh, their blood count's fine, their hemoglobin is 12 grams, and hematocrit's 41, but their sodium is only 120, and they've got acute kidney injury because they're super dehydrated. So that's why they passed out. So you can divide it into hemorrhagic and non-hemorrhagic. Don't forget, and I'm putting this up on the slide on purpose because we have a lot of patients in our catchment area who have cirrhosis. Liver cirrhosis is often either due to fatty liver disease, which is called non-alcoholic steatotic hepatitis, or NASH, NASH. We've got a lot of NASH patients here. Unfortunately, they're either hereditary or the way we eat, or alcoholic cirrhosis, which is due to alcohol consumption over a long period of time. It shrinks the liver. It makes the liver diseased in and of itself, where the liver doesn't function. All of a sudden, the liver is squeezed, creates portal venous hypertension, and as a result, the portal vein is under this much pressure going into the liver, and as a result, it puts back pressure on the portal system, and guess where a lot of that comes from? It comes from the gut. So as a result, the fluid leaks out, and presto changeo, ascites. So that's where ascites comes from. It's portal hypertension into a cirrhotic liver. Could be tumor too. Tumors can cause cirrhosis, you know, liver cancer and metastatic cancer to the liver from the breast or from the bone or prostate. So there's other reasons for it too, but those are the big ones. Also, patients can have a portal clot actually in the portal vein. Generally, that's a little bit more sudden and onset than the cirrhotic patient, just as an aside. Just fun things to think about. I like to treat you guys as clinicians, not as techs, because that's what you are. You know, anybody can follow a protocol ABC, but I like you guys to think outside the box and look at your patient. And it's always fun to go back and review your run sheets or think about John Doe that you took down to UMass and what happened, and think back and, oh, this is really interesting. Pathophysiology is really intriguing. So that's the third, and the fourth, but certainly not the least, is obstructive shock. That's a blockage. That's road construction. So you know how it is on Route 2 going from here to Athol, and that bridge work has been being done for months and months. It drives me nuts through there. It's like, are they ever going to get it done? You know, but you know how it is when you're sailing. We'll not say names, but when you're sailing down towards Fulton or Athol, and you're going 2 lane, all of a sudden down to 1 lane. It's really frustrating to go drop that speedometer from 71 or so, we'll say, down to 40. And especially if you see one of the policemen sitting there, it's like frustrating. Not that I've ever been picked up. I do tend to go a little bit faster there. But what happens in obstructive shock, you guys, is outside the heart problem. So this is not a heart attack, but this is a pulmonary embolism. This is an aortic thrombus. This is some kind of clotting process. This could even fall under a thrombotic stroke, for example. This is tension around the heart. This is pericardial tension or tamponade. Tamponade's dysrhythm. What's the dysrhythmia that you see with cardiac tamponade? Anybody? Bonus point. What rhythm do we see with tamponade? You'll see PEA. Yeah, PEA is a good one. Sometimes torsades, but PEA is big one for tamponade. And the way to treat that, obviously, is to stick a needle in the pericardial sac. And don't want you just trying it. Don't try this at home. So tamponade's a big one.
Ultrasound guided.
Pericarditis. Have you done one?
Not in a while, but
Yeah.
now they're ultrasound guided, so
Yeah.
makes it a little bit safer.
Easier to do. And I think as that develops in the EMS system, it'll be more of a guideline. So, yeah, I've done one in my career. Patient presented in PEA, and we kind of thought that might be, it was a last ditch effort. Of course. And sure enough, I stuck an 18 with a syringe, just a crude way to do it, and pulled some blood off. We did get a rhythm and a pulse back, but unfortunately there were a lot of other things and patients succumbed. But next slide, Tom, thanks. Okay, so can a patient, this is an easy answer, can a patient present with more than one source of shock? And it's allowed, yes. As you all know, our patients do not read the textbook and they do not come to us in a very orderly fashion. And they choose to just do everything and anything and present with things that are just totally don't make sense. I have numbness in my left third finger and my right fifth finger. And of course, it doesn't fit any kind of stroke thing. Or, you know, my left knee has been bothering me for 6 months. I'll call 911. Yeah, it's great. They don't read the textbook. So certainly if a patient is septic with distributive shock, they can also be hypovolemic because their infection, their pneumonia has been brewing for 3 to 5 days. And do you think anybody with pneumonia feels like eating and drinking? Certainly not. Yeah. You know how that goes. Yeah. You feel sick as fill in the blank. And the idea of eating rice or drinking beer is just a big turn on. Or if you have been vomiting, you certainly don't want to do that. You're on a cruise ship and you're seasick and throwing up, and the last thing you want to do is just, you know, try anything. And Gatorade's like major turnoff. Just the idea of drinking something citrusy when you're throwing up is a major turnoff. And that brings me to a question I've always asked: why do they flavor Tums fruit flavored? Because if you're really sick to your stomach, do you want to chew on citrus? Really? I don't know. Maybe. But that's just me. So that's just an aside. Next slide. Morning. So here's a little pathophys for everybody. It's fun to think about. Does it matter in the back of a rig when I'm treating a patient? I would like to think yes, because I would like you guys to think of why you're doing what you're doing. You know, why am I giving epinephrine? Why am I using push dose pressor? Why is the doctor at the ER all of a sudden giving this patient magnesium or an antibiotic or whatever it may be? Because at the cellular level, you guys, and why are we using oxygen? Because at the cellular level, guess what? One of the #1 problems in any shock patient, regardless of where it comes from, is oxygen. That's right, hypoxia. If Amazon is not supplying the widgets, what's the sense in ordering them on QVC or online or whatever it may be? You know, you can order 5,000 widgets for Christmas, and if Amazon isn't making them, it won't make any difference at all. If the body is demanding oxygen because it is being crushed, or it has pneumonia, or is fighting renal failure, if the body cannot get the supply it needs, then it's worthless. So the first thing we need to do is oxygenate our patient. It's reduced perfusion, it's not being delivered, it's not being consumed. Whatever the etiology, it doesn't matter. If you get there and your patient's got a pulse ox of 78, obviously they need oxygen. If they have a pulse ox of 94 and they look like garbage, they're diaphoretic and pale and cyanotic, and they've got a pressure of 80, are you going to give them some oxygen? I certainly would. Yeah. Treat what you see and what you feel, because you guys know, just as sure as I'm standing here, that an O2 sat on the finger is not always 100% accurate, correct? Just because this says 94, does that mean that they're perfusing correctly? Is there a ventilation perfusion mismatch because of a PE? Certainly could be. Or do they have carbon monoxide poisoning? Certainly could. That's shock too, right? Because they're not getting the O's they need. Their hemoglobin is hanging on to the carbon monoxide 3 to 5 times harder than it hangs on to oxygen. Wow, that's really cool. So CO poisoning can cause shock too. So at the cell membrane, what happens, you guys, and this is a progression of things, the oxygen isn't there. So the cells are starving. And when the cells don't get oxygen or they don't get glucose, they start to scream just like little kids in the playground. Or, you know, I'm not getting the ice cream before I have to eat the green bean. So guess what happens? The membranes start to break down. And this pump, the most important pump in the cell to make the cell do what it needs to do, is the sodium potassium pump. Sodium's on the outside of the cell, potassium's on the inside, and that exchange makes things happen, and it energizes and makes ATP, which is the energizer to make things work. The myocardial cell to contract the hepatic cell to get rid of the toxins in the body, etc. So when that pump fails, guess what? Cell doesn't breathe, and the cell doesn't breathe, it begins to break down, and that's called necrosis. We all know what necrotic tissue looks like, right? The cells die, and that leads to all this edema and all this cellular fluid being leaked out. Why do you think shock patients are either hyper or hypokalemic and their electrolytes are off? Why do you think the kidneys suddenly scream and don't make urine anymore? That's what's going on at the cellular level. Yeah, the exchange of electrolytes and toxins is damaged and dirt poor. And then behind all of this, the human body in all its wise wisdom decides we're going to set off an inflammatory cascade. Oh, that's just great. So let's send off bradykinins and prostaglandins, et cetera, and let's just send a bunch of white cells in there to cause inflammation. So now we not only have cell death, but we have all this inflammation and swelling inside the blood vessels that are already leaking. Oh, that's just wonderful. So that decreases the platelet stickiness. Platelets can't clot. The patient starts to bleed. They go into DIC, disseminated intravascular coagulation. I can think of a million scenarios. So the body is trying its best to protect us. And this is a compensatory mechanism. Works great in early shock, but then it works against us later on. This is one reason why we give Benadryl and antihistamines to anaphylactic shock patients, because it blocks the inflammatory cascade. Really cool, huh? And this is why we use steroids in patients in COPD and pulmonary shock, why steroids are being considered in neurogenic shock, why we give push dose hydrocortisone to patients that are in shock because of an adrenal crisis. Now it all makes sense, right? Why are we using steroids, antihistamines? It's because of the inflammatory cascade. Next slide, Tom, thanks. So here is some good stuff too. Major determinants in tissue perfusion. We all measure it, we all do it, and we all know how to do it. It's called your blood pressure. Simple, a vital sign that we all measure and follow. If the blood pressure is below 100 systolic, technically, if it's at 90, technically that's shock. So that's your definition, or a MAP, a mean arterial pressure of 65 or less is shock. So 90 or less on the blood pressure cuff, the sphygmomanometer, if you will, and the MAP of 65 or less. Some literature says 60, so 60, 65 isn't too bad. And a lot of our machines have the capability of measuring the MAP. There's a nice little formula for that, which I didn't put on the slide, and you can find that. Any of you have MD Calc as an app on your cell phone? It's really cool. It's free. It's a really cool app. It has a lot of calculators which you probably wouldn't use in EMS, and I think there are EMS calculators too.
Yeah, Hippocrates has some PalmEM.
PalmEM, yeah, I've got that. I forgot about that. I've got that on mine too. Yeah, PalmEM, that's the one you need. That has all those calculators on there. It has algorithms for ALS and PALS, drugs, pressor doses, all kinds of things. It's really handy to have. So anywho, this is an outline of measurements that we use in shock patients. What is your blood pressure? Your blood pressure is the cardiac output times the systemic vascular resistance. What does that mean in English? That means the resistance that your blood vessels are putting on your circulatory system. So that resistance comes in a fraction. The systolic pressure is the squeeze of the heart during contraction. The diastolic reading is the relaxation of the heart waiting for the next beat. So that's what your pressure differential is. And that is the mean, the difference between those is the mean arterial pressure at any one time. So this combined with the amount of squeeze or output that the heart is pumping at any 1 minute is your blood pressure. If the blood pressure goes down, it's either because the cardiac output is dropping, which is a product of the rate times the volume. So imagine a hemorrhaging patient, what's happening to their SV? Stroke volume is going down, right? So to compensate, to make up for the difference, the heart rate has to go up, right? It's a multiplication problem. Remember algebra or mathematics? To balance the equation, if one product drops, the other product has to go up to equilibrate what you're doing on the other end. So cardiac output has to increase, and that increases the heart rate. So SV is determined by the amount of load going into the heart, the amount of load coming off the heart, and the amount of contractility that the heart has. Now that leads me to another why. Why do we use norepinephrine and epinephrine as pressors? Both of those fall under the category of catecholamines. And what do catecholamines do? They increase the contractility of the heart and increase the heart rate. Norepinephrine not as much as epinephrine does, and that's why we use norepi in tachycardic patients a lot of the time, because it's a little less on that end, works really well. So we use these drugs to actually interface with these parameters that help us overcome a shock patient. Pretty cool. That's why I put that slide there. Okay, go ahead. Do you have access to the slides after the presentation?
If they go on, if they're posted online,
Okay.
like for Woods, yes, they'd see it when they play the video again.
Okay, that's cool. Yeah. Because if any of you at any one time need the slides sent to you, just let me know. And I can, they're on my stick, so I can just download them and send them to you. So the stages of shock, where do we intervene the best? The best we can do is in the pre-shock state. This is compensatory shock or cryptic shock. This is when they're sort of getting sick. They're maintaining a pretty good blood pressure maybe 102, 106. Heart rate's just going up. The patient's looking a little bit sick. They're starting to feel ill. Hopefully that's when they'll call and ask for help. We see this sometimes in the ER. Patients come in for, I don't know, fractured hip, for instance. So we're doing the workup and got the x-rays and whatnot. All of a sudden they're not feeling well. The heart rate goes up and respiratory rates maybe 28 or so, and their oxygen is okay, but they look like they're getting a little cyanotic. So we do our thing and listen to the chest, and boy, right lower lobe doesn't sound like it's perfusing or, getting air very well. Do a stat chest and looks okay. Well, this is a patient's just broke a major bone. Could they have a PE? Send them to CT, and sure enough, do an angiogram, and they threw a PE right in the ER. They're pre-shock. Shock is when this gives up, and the body between pre-shock and shock, sometimes it's very quick. Sometimes it can be over several hours. Sometimes maybe a day or so. It just depends on what's causing the shock. But believe me, you guys, it can happen quick. So even in the back of the ambulance en route, even if your transport time is a little short, let's say you're going from Gardner to the hospital at Haywood, that's a short run, but bad things can happen in a short period of time. You know as well as I do that 1 minute in the back of the ambulance is like 3 hours in the ER. It's just like awful. Those are the longest 14 minutes I ever had. You know how it goes. Next one, Tom, thanks. The bottom line of shock, you guys, is what we call end organ or multi-organ failure, MOF or MOD, multi-organ dysfunction. Basically what that is sad to say, a lot of the major solid organs start surrendering. We see surrender of the kidneys, certainly the heart, and dysrhythmias, cardiac failure, heart failure, cardiomyopathies, lungs can fail too, where they don't perfuse very well and fail to exchange carbon dioxide and oxygen. The brain, patients can get ultramental status or go into a coma. Liver, where you get transaminitis and eventually get liver failure. The gut can slow, and then you've got decreased gut motility, get distension, they can get valve obstruction. When the kidneys fail, the patients become oliguric, which means very little urine, or anuric, which means no urine whatsoever. So these are end organs that you may not see it in the field per se, but just so you know. With that being said, you will see some effects of end organ injury in the field, namely dysrhythmias, evidence of heart failure on auscultation to the lungs, JVD, maybe an expanding belly. You'll notice decreased pulses perhaps. You'll certainly notice vital sign abnormalities, tachycardia, bradycardia, hypotension, maybe tachypnea. So you'll see some of the end organ problems. So these are familiar to you. These are abnormal vital signs that you'll see on your shock patients. Shock patients will not always be cyanotic. They will not always be diaphoretic. If you see cyanosis or diaphoresis, certainly that could be shock. Can flushing and hives be an evidence of shock? Absolutely. That rubus, red skin, toxic poisoning, anaphylaxis from bee stings, you name it. So that can, skin color is very important to look at. And how are they warm? Are they cold? Is this patient febrile? Are they, or could they be, let me ask you this question, can they be septic with a core temperature of 96 Fahrenheit?
Absolutely.
Absolutely. Sepsis can cause hypothermia as well as hyperthermia. Don't forget that. So just because Grandma Moses in the nursing home, when you pick her up, she doesn't have a fever. In fact, she feels a little cool. I don't think she's septic, and she could be septic. So, and that being said, too, normal vital signs don't always mean that the patient is not septic. So keep that in mind too.
So if she doesn't have a fever, if she's not febrile, does that mean she's already gone into decompensated shock?
That could very well be, absolutely. Yeah. She can't mount a temperature anymore because her brain is responsible for that. And if the brain can't do that, that's a very good point. Yeah. Temperature is regulated by the hypothalamus near the pituitary gland. So if the brain's exhausted because of the shock to the system, yeah, it will not mount a temperature. Yeah. Metabolic acidosis, you guys won't see this, but you'll see signs and symptoms of it. You can see the patient tachypnic. They're breathing fast because they're trying to breathe off carbon dioxide to compensate for the acidosis. We see this in diabetics with DKA quite a bit. So that could be happening in any shock state, even in sepsis. In sepsis, we see tachypnea quite often. I'll agree you won't pick that up in the field unless the patients tell you or the family says something. I haven't been peeing very much in the last couple of days. Because there's no way of you knowing that unless you actually measure urinary output. And I don't think Foleys are in the EMS protocols yet to stick around. But
then your nursing home patients will likely have it, if they have it.
Right. If they have a pre-existing Foley, yeah, they can certainly. And you can look in the bag and you can see maybe there's only 100 cc's in there. And that's abnormal most of the time. Another clue, you guys, when you pick up a patient, if you notice they have a colostomy bag or an ileostomy bag, look at the contents and see if the bag is fairly empty and they haven't changed it recently, it might be a good clue that they're hypovolemic. They're not putting out. So same thing with the wound drain. If the wound drain is external, they've got like a J-back drain inside, that might be a clue that they're not putting out very much fluid. What this means is a measurement of lactate. I didn't have a slide on this, but another pathophys thing is the production of lactic acid in the body. What it is in a nutshell is when the cell is not getting the oxygen. Remember I told you that the sodium potassium pump shuts down, membranes start to break down and the cell leaks. Well, right before that, or as that is happening, the cell can't use oxygen for its metabolism, right? Because there's no oxygen there. So the cell starts anaerobic metabolism and starts breaking down proteins to grab what it can for energy. And the byproduct of that is pyruvate, and pyruvate is translated into lactate, and the lactate builds up in the blood. Lactate is not liked well by the body. It's considered a byproduct and one that we need to pee away and metabolize away in the liver to get the lactate back to pyruvate, back to protein chains that are stored on the membrane. But unfortunately, we can't do that in a shock state. So lactate builds up and they become hyperlactemic, if that's a word. Okay, we can measure that. some EMS folks around our state and our area, around the country, can measure lactate in point of care testing. I'm sure it's pretty expensive and takes some training, but the lactate is just a number that if it's above 2, I think it's measured in milligrams percent. If it's above 2, that's a warning signal that there's a problem. Now, all patients with elevated lactate are not shocked, and not all shock patients will have an elevated lactate. There again, just like everything else in medicine, it's not a perfect test, but it's one that we measure nonetheless. In the ER, we're looking for trends, just like with your troponin trending, and a lot of like blood pressure trending and everything else. If we're going up, we're going in the wrong direction. I had a patient at Athol over the weekend who came in with pneumonia sepsis. His lactate actually went from 4.1 to 5.2 to 6.4 in a matter of hours. So this guy was actually getting sicker as we're giving him treatment. We got his blood pressure better, and his MAP was good. His fever was down, but his lactate was going up. So that can happen as the patient starts to get better. You see this hump of not so good, and then you see the I'm doing better. So I heard tell that he is doing. We flew him to UMass. He's doing or Leominster, I should say. He's over in the ICU at Health Alliance and doing a little better today.
So would that be a dialysis issue? Getting that off?
It might be he had AKI and his GFR was trying to remember, it was either 30 or 32, somewhere in there. Yeah. He's not quite dialyzable yet because his creatinine was 2.3. Usually they don't dialyze until they get to 6 or so.
So how come you won't treat with like bicarb or anything just because it's not?
He's probably on a bicarb drip over there. I don't know the chart, but we often do that. We'll give them bicarb if they're hyperlactemic. Usually the doctors, if they're between 4 and 6, that's generally when they throw it. Another key to throw into bicarb is if their bicarb itself on the serum is less than 10. So depends on the critical care intensivist, what they feel comfortable with. Quite personally, I'm a little bit more liberal with bicarb. In a very critically ill patient, I don't think it's too much of an issue. The big debate in the literature is if we put them into metabolic alkalosis with too much bicarb. It's hard to retract that and to treat that. So
Take a bag over.
yeah, right. Just breathe into a bag. I'll get you a bag at Dollar Tree, no problem. Yeah. Okay. So any questions on vital signs and what we look for? You guys know these. Next slide, Tom. And I already mentioned these are and the one system I forgot to mention, which is silly of me, is your blood itself. Certainly anemia is a manifestation of shock because the red cells are swimming around going, "Que pasa?" Where's the oxygen I need to carry? I'm useless. So if I'm useless, the body doesn't like a useless cell. So what happens? It breaks it down. The body likes to recycle and reuse, and naturally will become anemic. So when you guys see medical records and you see anemia of chronic disease, that's where that comes from. These patients aren't in shock necessarily, but over time, their end-stage renal failure from their diabetes breaks down the red cells because the red cells aren't getting the nourishment they need because the kidneys are breaking down. The kidneys aren't making enough hemopoietin, which is a hormone to make the red cells work, and et cetera, and the red cells go. Okay, next slide. So, I just got a little artsy here. This is you guys. That's what I like to see is you guys at work. The initial treatment, and everybody knows this, is the first thing you learn when you're in school and you're training to be a first responder or an EMT, advanced EMT, paramedic, critical medic. The first thing we all learn at every level is the ABCs. Yeah. Without air and oxygen, we are dead. Without breathing and ventilating the oxygen, we're dead. Without circulating the oxygen, we're dead. So that's very important. And the D is right behind that, and that's the disability part. So we have to make sure that we got the oxygen going, that we can ventilate the patient properly, and that we can circulate the oxygen. So we manufacture the oxygen, putting the oxygen here. so we're Amazon. B, we're ventilating the patient, so we're doing the distribution, right? And C, if we're circulating, that's those up trucks in the mail, US Postal Service, getting the oxygen to where it needs to go. Right to your door, like DoorDash, it's pretty cool. So ABCs, and why I put that on the slide is not because I think you're dumb and not doing it. It's just a nice reminder, because all of us have been in situations where it's so chaotic or you're so stressed out that you forget the basics. How many of us, don't raise your hand, have forgotten a simple airway, like a nasal trumpet or oral airway, before you start bagging a patient? I know I have, so it's easy to forget the basics. Fluids. Don't be afraid, even with IV shortages, to hang fluid on a shock patient. That's what they need. Dan, if they're hemorrhaging, why am I giving them saline? Saline does not carry oxygen, does it? Absolutely not. But what you're doing is you're improving cardiac output by improving systemular vascular resistance, right? SVR. You're putting the fluid in there, it increases the pressure inside the pipes. And by doing that, you're actually making your patients well. You're temporizing, yes, but it's enough to buy time. That's what we do in pre-hospital medicine. We're buying time. Yeah. Yes.
Is Western Mass going to look into an infusion team? Because they're trialing it now in Region 5, and it's been absolutely phenomenal.
Wow, that's cool. I hadn't heard of that.
Yeah, they're mimicking the Texas model, and it's based out of Canton, like the truck, the
Yeah.
infusion truck, because it can hit all the access points of the highway easily.
Yeah.
And they do pre-hospital blood transfusions.
That is really
They've had a high
cool.
success rate. I think they're like at number 15 or something right
Yeah,
now.
and that's in the western sector?
That's the
Yeah.
eastern side.
That's really
But
cool.
yeah, they're mimicking the Texas model, I guess.
Yeah, Texas has been doing that for a year. Didn't know that, yeah.
But yeah, so
Wow.
it's based out of Canton right now.
That's
Dr.
really
Muse
cool.
out of Brockton is at the head of it.
Yeah. That's really cool.
Yeah.
I'd like to look
I
at,
feel because we have a lot of trauma out there that would benefit from it.
yeah.
And there's been plenty of times Medflight's not available. You know
Yeah.
what I mean?
What a great thing to have in rural states, Montana and
Yeah.
out in the sticks in Oklahoma and Texas. Life-saving, because they get the blood, that's what they need.
Mhm.
Yeah, do they just carry O neg or do they?
O positive, actually.
Yeah,
Yeah, because the studies show that there's a very slight, like 0.6%
Yeah,
overreactivity. So they look at
we've used O positive for massive transfusions.
That's the first question I asked on A negative. So I'm like, don't be giving me that. And they said, nope, studies show they vote every time go anyway.
Yeah.
Yep.
Oh, that's great. That's interesting.
Yeah.
Wow. So some other specifics, I've mentioned the epinephrine and anaphylaxis. Everybody knows that. If you've got a shock patient and anaphylaxis, they are losing their airway quickly. They need epinephrine. I don't think you can overuse it. The worst case scenario of epinephrine is tachycardia, big deal. They're going to burn it off. Epinephrine has a short half-life. It gets out of the body very quickly. So don't worry about tachycardia. Give it to them. How about the patient that's in shock because they've got a dropped lung? You go to the scene, they've got tracheal deviation to the right, you decrease lung sounds on the left side, JVD, and they're looking at you like they're going to die in a minute or two. It doesn't hurt to decompress that lung, does it? Second intercostal space, mid-clavicular line. Some studies nowadays said you can do it down in midline. I'm still old-fashioned, just go up above the chest. Get that whoosh of air and then put the chest tube in. It's a great treatment, and it's immediate, you guys. I've done this, and I've seen some great results with it. My one case I'll never forget, he was a front seat passenger in a head-on collision of a van. Unfortunately, his wife was driving the van, and he and his wife and the grandkids in the back were going to, or I forget how they're related, but to a graduation. And this was in Vermont, and they were coming up the hill from Berlin and heading into Montpelier. And the hospital, Central Vermont Hospital, sits up on the hill. So down over the hill on one side is Barrie, on the other side's Montpelier. And when he was coming up the hill, some drunk decided he was going to go down in the wrong lane and head-on collision. And this was daylight, afternoon, and the driver was killed. He was severely injured. He had C-spine subluxation. He had a pneumo on the left side, because I was on his left, remember. Pneumo on the left, splenic lac, contusion to the bowel, what else? Femur fracture on the left side. It was on the left because his left body obviously is closer to the point of impact, and some other injuries I can't remember. But when he came in, he was in shock, obviously, and really awake enough to realize what had happened, and kept asking him about his wife. And we already knew, but of course I didn't have the heart to tell him. I said, well, I don't know. My attention's on you. So we decompressed, and big bush of air. He instantly feels better. He was breathing right. It was just like very reassuring. So he made it. We sent him up to UVM, but unfortunately, some of the kids got really badly injured as well. But the outcome, the intoxicated individual, however, as you can imagine, yes, don't they all? Yes. Yeah. I don't know what the outcome was for him legally, but we were all very curious about it. It was an inward disaster call, actually, because there were 4 children, the gentleman, the drunk, and then the wife. Originally, we thought we'd have to bring her in, but then they called her at the scene. So we mobilized a lot. It was an internal code at the time. We had a lot of docs, surgeon, 2 surgeons, an anesthesiologist, an internist, hospitalist, OB-GYN. I don't know what they would do, but it was a good response from our team. All the nurses were there, so very helpful. So needle decompression. I'm sorry, I got sideswiped. Hemorrhage control. You guys know how to do this. If you need to give them TXA, and that's well within your right and protocols to do so, by all means use it. It does control hemorrhage very, very fast, and everybody knows ACRs for dysrhythmias. Next slide, Tom. Thanks. All right, a couple of cases, if you don't mind, because these actually are case reviews, so it kind of segues into the next segment. Do you want me to keep going, Tom, or should I break?
Well, there'd be another session, so.
Okay,
Yeah.
because I can wrap this up with these, and then I'll do the next session. That sound all right?
If you like.
Yeah, okay. So case 1, 84-year-old, he falls in his house, okay? He's at home. I don't think he uses a walker, but he was found by his wife in a prone position, and he'd been down what she thought might be 12 hours because he was okay when she left him for bedtime. I think it was 9 or 10 in the evening. This was early in the morning. He was awake. He had no complaints of any pain, which is really interesting. And he just wanted off the floor. He just couldn't roll himself over to do so. When he was rolled over by EMS, he was found to have some bruising of his chest and his abdomen. And interestingly enough, there was a step-off type of deformity that was noted. I thought that was intriguing. At C5, C6 verified in the ER. His distal sensory and motor is intact, so he's got good feeling all the way down. Vital signs don't look too bad, right? Yeah, so he's hypertensive for sure. Heart rate is normal. Respiratory rate, give or take, is okay. I like his saturation. Blood glucose is only 71. Kind of on the low normal side, but not too bad. Okay.
He's in it for 12 hours.
Yeah, that's pretty darn good for 12 hours on the floor. All right, now another little monkey wrench to throw in here, which I didn't put on the slide. This guy, we found out, had been drinking. So he had 3 whiskeys before he went to bed. I don't know, drinking whiskey before bed just doesn't sound right, but anyway, next slide. In the ambulance, naturally, and this is when the patients like to get the sick worse, he crumps naturally. So you pick up a stable looking, doesn't look too bad patient, you put him on the cart, you're all ready to go and give the dispatch to the hospital. Here I come. And all of a sudden he drops. Shock or no shock? That's shock for sure. Interesting, he doesn't get tachycardic. Now, you can see where I'm going with this one, right? His respiratory rate goes up and he's got labored breathing. So smart people that you are, you place this patient in a Trendelenburg position, modified. I'm sure you can't do too much in the back of the ambulance, but you give him a 500 cc bolus of saline, 100% oxygen, all very appropriate, which is great. 12 lead shows atrial bigeminy. It's another little hint as to what's going on with this guy. Atrial bigeminy needs PAC every other beat. So normal beat PAC, normal beat PAC. It's not a deadly dysrhythmia, but it's one to take notice of. On arrival, we pick him up and we look at it with like two heads. You told me this patient was in shock and he looks great. And that's because, doctor, and then you slap me across the face, I treated him right in the back of the ambulance. I did what you taught me to do. Oh, congratulations. You are EMS of the year. So on arrival, he looks pretty darn good. What do you think's causing the shock in this guy? Rhabdo, very good. Rhabdo causes dehydration, muscle breakdown. The kidneys do not like myosin. Myosin is one of the things that's released from muscle tissue. Kidneys don't like it very well. And myoglobinuria is not a good thing, and it shuts down the kidneys, makes the patients dry and dehydrated, goes into shock. Next slide. Take-home points on this guy. This guy also had a step-off deformity at 5'6". He had a subluxed vertebrae. That means the vertebrae slid forward, and as a result, this guy had some cord trouble. Fortunately, the MRI did not show damage to the cord, but he had some swelling around it, some edema. I don't know why this guy didn't have motor sensory problems. I'm surprised.
Jim Beam.
Yeah, he had alcohol numbed him. Yeah, he had anesthesia. So this guy had a subluxation or dislocations was completely off. So cervical dislocation or subluxations can occur with no neurological symptoms. And I had to look it up to be sure. Yeah. So can a patient have a cord or spinal column injury without symptoms? And the answer is yes. So there again, take home point, always be suspicious of cervical injury when you pick up your patient. You guys are really good about collars. I've seen collars, and some of the other techs and the nurses get kind of wigged out about why they put a collar on. Well, you never know. You know, why did I put a collar on the guy that walked in the ER? He walked in and put, why are you here? Well, I've got a headache. Why do you have a headache? Because the garage door that I was installing came down and slammed me in the head. Those springs, those big springs, they gave way and they weren't attached right and slammed him in the head. Sure enough, he had a compression fracture, C5. Patient I had in Vermont. Yeah. He walked in. Oh my, I've got a headache. That's all he had. Oh, yeah, no more than that. Bought yourself a Miami J for 9 months or whatever it is. Toxins from this crush injury, as you mentioned, Dane, the rhabdo is certainly a contributor to a shock for sure, and he's probably dehydrated. Dehydration from I haven't been drinking water and I drank alcohol, and alcohol can dehydrate you. Next slide.
And the rhabdo will clog up your kidneys and you won't be able to put out even
Big
if you
time, you
work.
can't, it's even worse, yeah. So case two, Dan decided to get artsy again. This is a 40-year-old, and he decides to give you a call because he's had 3 days of cough and a low-grade fever. You already know where this is going, right? He's found by his spouse on her return from work. So she comes home from work and finds him a little confused. Well, a little more confused than husband baseline, we'll put it that way. All husbands are a little confused according to their wives. And his temperature's pretty high. He feels really warm and flushed. He's got these vital signs: shock or no shock? Shock for sure. He's hypotensive by definition, tachycardic. He's tachypnic, he's febrile, and he's hypoxic. Wow, hypoxic and hypotensive. Yeah. Not a good combination. What do you think his cardiac output is? Compromised? Sure. Yep, he's got compromised cardiac output. You know this right away because blood pressure is a measurement of output. So you could always radio in and go, yeah, we're bringing you this 40-year-old male and his cardiac output's compromised. Yeah, put the radio aside. I can just see Sheena standing there. What? WTF? Yeah, it's like, No, no, you don't need to say it on the radio. You can just talk to me about it. So we know that he is not perfusing well, right? He is in shock. In what kind? Septic shock. Very good. Next slide. Yep, he's septic shock, very likely. And we learned that this guy just got back from a business trip to Japan. So that widens the spectrum of what could this guy be sick with. Did he pick up COVID on the plane, or did he pick up some Japanese bacteria of some sort? Chances are that Japan has much the same bacteria as we do. They've got strep and mycoplasma and all that. By the way, you guys, we've seen an uptick in mycoplasma pneumonia, as you may know from reports from DPH. So keep that in mind. That's an atypical pneumonia, and that can certainly cause patients in shock. He was resuscitated with 2 liters of saline. We gave him Tylenol for a fever, but guess what? After 2 liters, this guy did not get better. What's the next step? Pressors, right? And we use pressors in shock for reasons that I told you earlier, because we're increasing systemic vascular resistance to make a difference in cardiac output, right? Next slide, Tom, thanks. So vasopressors can be used when fluids alone do not work. The vasopressor of choice in most cases of shock, including septic shock, is norepinephrine. It's similar to epinephrine. The nor in front of it is because it's chemically a little bit different. That's beyond the scope of what I need to teach you now, but being a chem major in college, I get all pumped up about it. But anyway, norepinephrine or Levophed is also used in cardiogenic shock and hypovolemic shock. So it's kind of our go-to. So those of you that are authorized and credentialed to use pressors, that's your go-to, which I'm sure you've used a lot. Norepi works really well. So consider this use. Here's your goal. Every paramedic or critical medic knows that your goal is 65 or more. And for those of you that don't use pressors, it's nice to know anyway. Next slide, Tom. Okay, this is a brief look, and this, for most of you, this might be beyond your scope of practice, but it's good to know. These are the doses, and this is on that Palm ED app, as well as MedCalc app, so you can look it up. But why do we use phenylephrine? This is neosynephrine, by the way, nasal spray. This is really good to use when you've got concerning tachyarrhythmias or tachycardia. So this is a patient maybe with WPW or SVT or sinus tach because they're so sick and you can't get them down. You can't get that heart rate under 130 or so.
Pure alpha.
Yep, it's pure alpha. That's right. It doesn't affect the heart rate at all. So good stuff. We use phenylephrine quite a bit in the ER too. Next slide. These are some other vasopressors that we use, not as often. These are second line, sometimes third line, because of the side effects and the effects that they have. Dobutamine we use in cardiogenic shock patients that have really blown their ventricles. A lot of times these patients are headed for LVAD and external ECMO, and that really bad sick patients. Vasopressin is an add to. It's not a vasopressor by itself, but we add it on to norepinephrine a lot of the time. Yeah, next slide. So here's the conclusion. Everybody likes to see this slide. That means a break. If you suspect and have a suspicion of shock, then treat it. Start with the oxygen, start with the fluids. Just like you have a suspicion of hypoxia, or you have a suspicion of a neck injury and you put them in a collar, or you suspect that they're bleeding internally. You guys know what I mean. If you think it, then you can be prepared for it. In medicine, I always tell everybody I train, whether it's nurses, EMS, medical residents, or students, if you think the worst and work backwards, you're going to be a winner. So always think that chest pain is an MI, it's a dissection, pulmonary embolism, tension pneumo, belly pain is a disruption or it's a dissection, etc. Think the worst and rule it out, work backwards. Ankle pain, not necessarily PE, but a sprained ankle could certainly set off a chain of events, right? So think the worst, suspect it as part of your differential. Start with the basics and work yourself up. Always ready yourself to think, if you're a medic, you always think, man, should I be thinking pressors here? You give them the 30 cc's per kilo, and if they've reached their bolus max, then start thinking pressors. Okay, next slide. Any questions? Or Dan, what's the name of this painting? Yeah. I think the name of this painting, I'm glad you asked it because I now forgot. What was it? Night call or house call or something like that. Yeah, but yeah, the artist really captured the moment. When I started medicine and family medicine, of course, my heart was in emergency medicine too, so I did a little bit of that. But I did this. I made house calls, and there were a couple late nights like this. One night that's similar to this was in an Amish home, and I sat next to a child. Eli was 12 years old, had a fever, and was starting to develop abdominal pain. And I was really worried that he was developing appendicitis. Hours later, he manifested a temperature 102, started getting McBurney's, getting really sick. So Laura and I loaded him up in our Explorer at the time, took him to the hospital. I called my surgeon, who graciously saw him in the waiting room. This is around 5:30 or 6 in the morning. Saw him in the waiting room, so we didn't even register him as a patient. Dan will take him right to the OR. So we ordered the labs and stuff and the IVs as an outpatient to save them, because they don't have insurance. So we saved them some money and took him to the OR, and then Dan admitted him as an outpatient from surgery. Sure enough, he had acute appendicitis. Did very, very well. And Laura and I, because we drove him to the hospital, we ended up being their taxi cab back to the house. Yeah, we were rewarded with a beautiful set of tray tables that were made out of oak. Those coffee tray tables that you can fold and put up. We got a beautiful set of those and some cantaloupe. So that was my painting. Well, thank you for your time. I hope this was very, very good. I'm sorry I went over a little bit, but there's a lot of information, and I wanted you to really wrap your head around shock. We'll take 10 minutes, and then these forward 20 minutes will count for the second hour. Can we?
We'll figure it out.
Yeah, we'll do it. As long as you all are present for the 2 hours, that'll work. So we'll take what, 5, 10?
Yep, long enough for people to do what they got to do at home. The link for the next one I just put in the chat if you don't have it already. It'll give us time to reset and go on over. So, alrighty. Any questions from the chat? Now's the time.
Oh yeah, do I?
I think there were some people I didn't have numbers for yet. So if you haven't done it now, speak now, forever hold your peace. All right, recording is going to be done, and we'll switch over in a minute. So I need to deal with this one.
Yeah, I love that painting. I tried to find one to hang in the office. I'm sure you can find that.
Recording.